Hello doctors, I'm your med buddy Arun, and in this lecture I'm gonna talk about ECG, that is electrocardiogram. What is an ECG? ECG is the graphical representation of the electrical activity of the heart. It basically tells about the electrophysiology of the heart in form of a graph and where it is represented in form of wave. And to understand the meaning of these waves, we must have very basic knowledge of vectors. In case of heart electrophysiology, there is current vector that is gonna be presented on a graph in form of wave. And to present that current vector on a graph that is in that electronic machine, we are gonna present that vector produced by the heart on a graph in form of a wave. So let's understand that. What is a vector? Any quantity that is measured using two components, that is direction and magnitude, is called a vector. A vector can be presented in form of an arrow. In this arrow, the head represents the direction while the tail represents the magnitude, and we call this thing a vector. Now the same thing can be presented in form of a graph using an electronic machine that forms the ECG. So this vector that is having direction and magnitude can be presented in form of a graph. Let's see how. So let's understand how a current vector that has magnitude and some direction is going to be presented on a graph by the use of ECG machine. So here, this is the current vector having direction presented by the head of the arrow and magnitude presented by the tail of the arrow. And this vector is received by this lead. We have fixed the lead in different directions with the same vector. So here the lead is receiving the same vector but directly towards the direction of that vector. So let's see how this lead is going to receive it and how this ECG machine is going to present it in form of a wave. So here is the direction of the vector towards the ECG. By the ECG machine, it is going to be presented as, because it is moving towards the lead, directly towards the lead, it is going to be presented as an upward moving line. But the height or amplitude of this upward moving wave is going to be decided by the magnitude of this vector. So it is something like this, an upward moving wave with some magnitude, and in this wave this amplitude is the magnitude of it. Now here is the same vector, but now lead are placed facing towards it but from a different direction. Now let's discuss this lead first. The vector is perpendicular to the direction of the lead. Alright, so how is it gonna be received by the lead? For understanding this, let's imagine a car. You are standing on footpath and a car is coming from very far towards your left. How are you gonna say that what that car is? You are gonna tell that that car is coming towards you, but it is in a direction, that direction is perpendicular to you. So that car is coming towards you. Now that car is going away from you. So let's understand it. That car is a vector. It is coming towards you and it is going away from you. Alright, so same thing is happening with this lead. So the direction of this vector is towards the lead up to some point, and after that it is going to be away from the lead. So firstly it is coming and then it is going. So here are the two components of this vector's direction. One component is coming towards the lead and another component with the same magnitude is going away from the lead. How is it going to be present? So first of all, it is coming towards the lead, so it is going to be presented like this, a positive wave. And then also it is going away from the lead, it will be coming like this, a negative wave. And the difference of the amplitude is the final magnitude of this wave, is the final magnitude perceived by this lead. Now let's discuss this lead. From the point of view of this lead, the vector is going away. It is going away from the view of the lead. So how is it going to be present? It is going away but with the same magnitude. So our largest component of this vector's direction is mostly away from the lead. A very small component is towards the lead. A very small component, because it is at a very small angle towards the vector. That's why there is also a component which is towards the lead. So how is it going to be present? So because the largest one is away from the lead, so it is going to be something negative, a large negative. But a small component, very small component is towards the lead, then it is going to be present like this. So something like this. And again the final magnitude will be the difference of these two amplitudes. Now let's see, the vector is coming in the pulsatile manner. How is it going to be presented by this lead which is directly in direction of this vector? So first of all, this vector in the direction of the lead will be perceived by the lead and it will be presented as a small magnitude, positive direction but very small magnitude. And then a large magnitude is coming, but with a time lapse. Here between two vector there is also a time gap, so there will be a time gap and then a large magnitude is coming, and this will be presented like this. Clear? So now let's understand how the same thing is going to happen with the heart. So to understand the current vector produced by the heart and how it is presented by the ECG, we have to know what are the sources of this current vector. So in the heart we have SA node, AV node, left bundle branch and the right bundle branch, and the myocardium. These all are the sources of producing a single current vector. So atria is producing its current vector, also right ventricle is producing its current vector, and left ventricle is also producing its current vector. Then how do we define a single current vector? Let's see. The largest current vector that is going to be present by the heart is from the left ventricle. How? Because left ventricle is the largest. It has most tissues of myocardium, and the another contribution comes from the right atrium. In comparison to left atrium, right atrium is the largest, and in comparison to right ventricle, left ventricle is larger. So let's see, a small current vector is produced by the right ventricle. Also a large, very large current vector is produced by the left ventricle. A large vector is produced by the right atrium, and also a very small current vector is produced by this left atrium. So how is it gonna be presented on ECG? On ECG, a single final vector is going to be present. The largest vector will be the mostly presented vector on the ECG, and this vector will be covering all other vectors because it is largest, and on ECG only it is going to be perceived. So let's see how an ECG is going to present this vector. Here we have placed one lead directly in the direction of the vector. Where is the vector? Here is the vector. Here is the final vector that we have set, and another lead is present in this direction. So eyes of this lead is directly in the direction of the largest vector. How is it going to be present? Let's see. So first of all, there will be depolarization of the atria. A vector with magnitude and direction will be produced by the atria very first. How it will be? Because its direction also is towards the lead, because it is also the smaller, and with other factors it is gonna come like this: a positive wave but a circular wave and monophasic wave. And there will be AV nodal delay as well. So it is gonna take time for the current vector to reach from here to here and stimulate all this myocardium. So there will be a time lapse, that is gonna be this. Then the largest myocardium is going to produce the another vector, that will be again the positive, which means towards the direction of this lead, and with a large magnitude. The amplitude of this wave is the magnitude of this vector produced by the heart. And then there will be a delay before the repolarization, and repolarization of the larger myocardium is again gonna produce a small vector which will be like this. So the vector produced by the right atrium, actually by the combination of right and left atrium, because they both are getting depolarized at the same time, but it largely shows the depolarization of right atrium, and covering also there is depolarization within this wave. There is also the depolarization of left atrium, but it is covered under the depolarization under the larger vector of right atrium. That's why we cannot see it separately. And same applies here, because left ventricle is larger, it is covering the depolarization vector of right ventricle as well. We cannot see it here because it is the larger and it is covering the smaller one. So this is the P wave, QRS wave, and the T wave. So this is how ECG is going to present the vectors of the heart. Now let's see how this lead is going to present. So again, this lead, let's make a parallel vector here, and here is that lead. It is something like this. Okay. So a very small component of this direction is towards the lead, while a larger component is away from the lead. So how is it going to be? It can be biphasic, a very small component towards the lead while a larger component away from the lead in the P wave as well. Moving up, a smaller component, again here applies the same, smaller component towards the lead and a larger component away from the lead. And this is how it is going to be present. Here it is the P wave, it came to be biphasic. Q, R and S wave, here also it is going to be biphasic, and T wave. And the time lag that is between the depolarization of atria and ventricle is the PQ segment, and between depolarization of atria and the repolarization of ventricle is going to be the ST segment, that is depolarization of the ventricle and again its repolarization, that is the ST segment. So this is how ECG is going to present the vectors of the current vector of a complete heart in form of a wave. Now let's talk about a 12 lead standard ECG which is usually used in healthcare facilities. 12 lead ECG, by the name we can know it have 12 leads, that are 6 unipolar chest leads that are placed right on the chest, named as V1, V2, V3, V4, V5, V6, or can be named as C2, C1 to C6. And what are their location? V1 is placed right in the fourth intercostal space on the right sternal line. Fourth intercostal space, this is the sternum on the right sternal line. The V2 lead is placed in the fourth intercostal space on the left sternal line. V3 is placed right below the V2 on the fifth costal cartilage. The V4 is placed on the mid-clavicular line in the fifth intercostal space. This is the fifth intercostal space, and this is the mid-axillary line, mid-clavicular line. V5 is placed on the anterior axillary line in the fifth intercostal space, and V6 is placed on the middle axillary line, again on the fifth intercostal space. So this is the placement of V1 to V6 unipolar chest lead. Another comes the 3 unipolar augmented limb leads. These are also the limb lead that are placed here, here and here. Maybe also they can place here or here or here. And what are they named as? They are named as AVR, that is AVR on the right side, AVL, this is AVL, and AVF, that is AVF. And the last comes the bipolar limb leads that are named as 1, 2 and 3. These leads are placed, actually unipolar augmented limb lead and bipolar limb lead are in the same apparatus. They are in the same instrument and they are placed on the same place. Now let's understand how each of these leads have their view towards the heart from different direction, and how they present a 12 lead standard ECG. Now let's understand the waves presented by each of these group of leads by ECG. So here we have unipolar limb leads that are V1, V2, V3, V4, V5, V6 placed as they are placed on the chest. So let's start from V1. You can easily observe that this V1 lead is not directly in the direction of the largest vector, but a larger component of this vector is moving away from the lead and a smaller component is towards the lead. So in most of the cases what appears is something like this: a very small biphasic P wave, a smaller component is towards the lead and a larger component is away from the lead. That's why a large QRS wave in negative direction, and then a T wave. So this is something that is presented by V1 lead. let's talk about V2 lead. V2 lead, again, a larger component is away from the lead while a smaller component is towards the lead, but it is quite larger than V1. So here we are going to see a positive V wave, a positive P wave, followed by a little larger positive component and really big negative component, and a T wave. This is something that is presented by V2 lead. Now let's see V3 lead. It is again something like this, P wave. The size of positive component is gradually increasing, you can notice it. So here it is something that is presented by the V3 lead. Now let's see V4 and V5. The largest component is directly towards these lead, and it is going to present something like this, a very large positive component and negligibly smaller component, something like this. Similar thing will be appearing on V5, while on V6 it will be quite smaller. It is something like this on V6, V4 and V5, V3, V2 and V1. So this is how unipolar limb leads present the graphical presentation or ECG of the vector presented by the direction of overall current vector that is produced by the myocardium and tissues of the heart is called the cardiac axis. It is the direction of overall vector of the heart. And what is the normal cardiac axis? When we see it in a circular graph, we can see that the normal axis of heart is lying between -30 to +90 degrees. What does that mean? Within this axis, you can see all the leads that are lying within this axis are largely going to be positive, or largely the positive, or having a very small negative part, while which are not lying in this axis will largely be having a negative direction with a large negative magnitude and a smaller positive magnitude. That is what we are going to observe on a 12 lead ECG. And when there is any deviation, when the vector is not in its axis, either it is towards the left or towards the right, or very much towards the right, we call it left axis deviation. When the vector has shifted from its normal axis towards the left, that is, the normal axis is -30 to +90, when it has shifted away from -30, that can be from -30 to -90, this will be called as the left axis deviation. How this can happen? Let's see. Now let's guess the person is going through a chronic hypertension. What does chronic hypertension do? It can cause hypertrophy of left ventricle. So when there is hypertrophy of left ventricle, it means that the larger number of tissues are present in the left ventricle. So the contribution towards the vector, the contribution in the vector will be largely from the left ventricle. That's why there will be a shift in this vector towards the left side. Now let's say there is damage to the myocardium. There is loss of viable tissues in the myocardium on the left side, then the tissues here have become infarcted, they are dead, and they are now not contributing in producing the current vector. Now because of this, there will be a shift in vector, and this shift will be towards the right, because the cells in the left one have died. That's why this has shifted towards the right, as most of the contribution now is coming from the right side of the heart. Now let's say there is hypertrophy of the right ventricle, and on the same time there is damage to the right heart. Then it is going to be an extreme case where the most of the contribution is going to come from the right ventricle, and we are going to call it extreme right axis deviation, ERAD. And how, using a 12 lead ECG, we can easily find it out. Let's see. We have two lead, the lead 1 and the AVF. Lead 1 is a bipolar lead, and it looks at the heart completely right at the horizontal direction, while AVF looks at the heart right from the vertical direction. So using these two leads, we can easily tell if there is an axis deviation or no. So in most of the cases it should be positive. All right. So if there is positive wave in first bipolar lead and positive in AVF as well, it is the normal axis of the heart. We can easily guess that it is the normal axis of the heart. And if there is positive wave in the first lead and a negative wave in the AVF, now see how it is going to work. It simply means that the axis has deviated towards the left, which means it has deviated more towards the first lead. This is the normal axis, and it has deviated more towards the first lead. That is why the first lead is positive and stronger, while the AVF, that is right in the vertical direction of the vector, here we can easily notice, because the vector has now shifted away from it, it is going to become negative. So we can say it is the left axis deviation. Now if the first lead is negative and the AVF, the vertical lead, is positive, it will be the right axis deviation. How? Now this is the axis, and it has, let's see, deviated towards this side. So the complete axis has shifted towards the right, which means now first lead is not in the axis of heart. That's why it has become negative, and the AVF has become positive and even more stronger, because the axis is now pointing more towards it, and we are going to call it right axis deviation between 90 to 180 degree. Now let's say both the waves, the horizontal as well as the vertical leads, are presenting the negative wave. What does that mean? The axis has shifted too much that it is now neither in the vertical direction nor in the direction of first lead. It is neither in the direction of AVF nor in the direction of first lead, which means it has completely shifted. It has extremely shifted, and we call it extreme right axis deviation. It lies between -180 to 150. Let's see again. The left axis deviation towards the left due to, let's say, ventricular hypertrophy. Where does it lie? It will be lying between -30 to minus 90, right in this region. It is the region of left axis deviation. If there is right axis deviation, that is a little bit right here, this complete region is going to be the deviation towards right axis, and it happen in such condition as I already explained. And if there is extreme right deviation, this region is the region of extreme right axis deviation, that is between minus 180, that is between 180 to minus 150. It is the extreme right axis deviation. Now let's see what are the common pathologies that can cause it. Left axis deviation is mostly seen in left ventricular hypertrophy and left bundle branch block. There can be many other reasons for this, but in clinical practice you are going to meet these cases mostly: right axis deviation, right ventricular hypertrophy, again blockade, or APs, that are accessory pathways. These will be the most clinical cases that you are going to see. And extreme right axis deviation are mainly seen in ventricular tachycardia and right ventricular hypertrophy as well. So this is all about the axis of the heart, and I hope you understood it well, and thanks for watching.